Oh, oops. Didn't mean to open that, but that's the right one, right?
Yes.
I did adrenal and thyroid.
Huh. Morning. I'm surprised anyone's showing up.
No, this is pretty good this year. We're coming.
Yeah.
Even in the rain, but if you live across the street, the rain's not that bad.
I didn't take off my rain boots.
I was so bummed I missed Ella's party.
Yeah.
She said she'd be around maybe at the end of June.
Yeah. Unfortunately, I don't think I'm going to be around end of June, but oh well. But she got into UCLA.
Oh, that's fantastic. Is that where she's going? I emailed her and was like, I thought she was going downstairs.
Yeah, she was. And I think Friday afternoon.
This Friday?
Like a week ago.
Oh,
no,
wow.
the week before. She found out. Really?
Oh, looks great.
Oh my gosh. I
Looks like
just
you got it done.
Oh my god, it's the humidity.
Well, it works for you. Doesn't for me.
The humidity just did it.
Oh, that's great.
Oh yeah, she's so wonderful. She's thrilled.
Yeah.
Oh, I keep forgetting to wear something with a waistband. Is this?
This is a microphone. I know it's on mute. Just switch
Okay.
it over this way, and it works. So
Okay.
whenever you're ready, you can do that.
All right.
Flip it wherever
Yeah.
you'd like. Yeah, usually it works best like close to your mouth. Otherwise, people can't hear.
Like
That
that.
should be good. They'll let you know, like, if not.
They'll let you know if they can't hear. I
The
sit in the back
students
too,
will let
so.
me know. Okay.
And then
Looks like a clip here.
so this button's the laser pointer, and then forward.
And we added hysteria, Bellevue, and all this stuff to the drug list. So those are things that you have to know, and I saw it on your slide. So,
Okay, good.
so they're on the list of drugs they're supposed to know. So
So this is in a syllabus that they have?
not a syllabus, we just send them the list of drugs. They don't really have a syllabus. It's more like they're using the slides and there are 2 textbooks that are recommended. Some people send out a syllabus anyway,
Right.
but in the past they haven't wanted a syllabus, but sometimes people do because then it's like extra stuff you have to know.
Okay.
But we say it's not required. You can leave the syllabus if you want.
Okay.
Actually, I think you can get started whenever you want. So
And
This works
it's
too
till,
if you don't
it's
know.
till 9:50, right?
yeah. And then Teresa and Heather.
Yeah, I'm going to stay for that.
Oh, okay, good.
Okay, good morning. Good morning. Can you hear me? Can you hear me? Hello? Hello? Hi. Good morning. So I'm Dr. Corner, and I'm just going to talk to you about obesity, define it, why we think it's important, and also some of the treatments for obesity. And I know that you may be familiar with these slides, but I've seen this slide dozens and dozens of times, and every time I look at it, I'm still amazed. And this is the prevalence of obesity, which we define, even though it's an excess of body fat, you can't really measure body fat clinically, so we use a surrogate marker called the body mass index, or BMI. And obesity is a BMI of 30 and above. So when you're on the wards and you're presenting a case, don't just say that this is an obese 43-year-old so-and-so just because you think they're obese. Really do measure the BMI, and it is important because a lot of our treatment strategies are based on BMI criteria. And if you use that as a criteria, we see that, that the prevalence of obesity has really skyrocketed. These are color-coded charts in 1990. You see that the prevalence is mostly around 10 to 14%. 10 years later, the prevalence increases, and now you see between 20 and 24%. And then 10 years after that, you see new colors added to the map. And probably about more than 30% of the nation is obese, and almost 2/3 of the nation is overweight. And this is a worldwide epidemic, actually. And the CDC says that this increase is really more like an infectious disease process and not the type of increase you would see for a typical chronic disease. And this is why we care about obesity. Certainly it is a cosmetic issue, but I don't care if you are going into internal medicine or any of the subspecialties, radiology, dermatology, pathology, neurology, even surgery. Your patients will be adversely affected by obesity and will have diseases that are either caused by an excess of body fat or are worsened by an excess of body fat. So it's important to keep all of these other diseases in mind when you are treating an obese patient. And this is just an example of the risk factors for obesity. This is the relationship between BMI and the risk of developing type 2 diabetes. Here you see the BMI in the, there we go, on the x-axis, and overweight is a BMI of 25 and above. And here you see the risk of developing diabetes, and you can see it skyrockets. So the people who you're going to be treating in your clinics as physicians are most likely going to be more in this area here. But even so, it's important to really recognize any weight gain that is occurring. And since you'll see treating obesity is difficult, if we could prevent it, that's really the best approach. And this here is the other slide kind of blown up in more of the normal range of body mass index. So you can see that any weight gain, even when you're in the normal range, increases your risk for developing type 2 diabetes, cholelithiasis, hypertension, and coronary heart disease. And that's just not coronary artery disease, it's also heart failure. So if a patient is coming to you and they're saying that they've gained 10, 15 pounds, we need to take that seriously. Because they are moving along this scale here. So how do we treat obesity? No matter what we're doing to treat obesity, whether it be adding pharmacotherapy or surgery, this is the cornerstone. And you'll hear more about this in the next lecture. But even if you put someone on a drug, that drug is just a tool to help people still pay more attention to their behavior therapy and their diet. And they'll do much better if they do so. And this is an example of the power of behavior therapy and diet. This is actually one of my favorite studies. It's the Diabetes Prevention Program. And what they did was they took individuals who were at risk for developing diabetes. So these were non-diabetic persons. And they just had to have elevated fasting glucose or 2-hour postprandial glucose. And they didn't have to be obese. But since these individuals are at risk, they ask, well, is there something that we can do to prevent the progression to diabetes? And they had 3 arms. They had a placebo arm, an arm that got metformin, which we usually use for the treatment of diabetes, and an intensive lifestyle intervention. So there were weekly meetings, group meetings. The goal was to get individuals to lose about 7% of their body weight. Most individuals did not lose that much. they lost 5 to 6 kilos in the intensive lifestyle. But they actually stopped the study early because these results were so profound. If you incorporate lifestyle changes, and you don't have to lose pounds and pounds of weight, you will decrease the chance of developing diabetes by 58%. So this is quite remarkable, and it is sort of a real eye-opener into what we need to do, and that we don't have to have people turn into lean individuals. So the one thing that they don't have here is lifestyle plus metformin. We don't know if that would improve. So I do encourage you to consider lifestyle changes and the power that that can have. On the other hand, we have here a meta-analysis of the success long-term of lifestyle changes in terms of keeping weight down. And here we have a meta-analysis of individuals who were placed on a very low-calorie diet that's usually less than 800 calories a day, or behavior modification, or a combined treatment. And when individuals are in a study or in a program, you can get them to lose weight, but then you say, take what we've learned, what you've learned, and continue with that. And invariably, within 3 to 5 years, what we see is weight regain, and usually to a level even higher than what it was before treatment. So we need to help patients with other tools other than behavior modification and diet, because that doesn't always work. And why is that? So I think when we treat obesity and we think of obesity, we don't always think of drug therapy like we do with other diseases, because there is this notion that if you take a pizza, well, there'll be this one person who has one slice, and there'll be the other person who has several slices. And the traditional role is really that the person who has several slices is gluttonous and hedonistic, and the person who has one slice is exerting wonderful willpower. Well, there are physiological reasons probably that exist between these two individuals. So if you ask this person, well, have another slice, they'll say, I can't. I mean, I've had my one slice, I feel full, I feel satisfied, I'm not going to want another slice. So that's not really willpower, that's just the way they're listening to signals in their body. If you talk to this individual, they just don't seem to be getting the signals of satiety and decreased hunger that this individual is getting. And it's not necessarily driven, their intake is not necessarily driven by gluttony or hedonism. And we have to start thinking about the differences between individuals more in the realm of biology and not in the realm of just whether they're gluttonous or not. And we've learned a lot, actually, in the past couple of decades. And a lot of that has stemmed from the discovery of leptin. And this is just an example of one way the model of obesity works. And this is a very intricate system that's regulated like most other systems. And for example, if we have leptin, that's made by adipose tissue. And leptin does talk to the brain, mostly in the hypothalamus, and it basically increases energy expenditure, decreases hunger, decreases food intake. But what happens when a person loses weight? Decreased adipose tissue, you have decreased leptin, and what the brain is seeing that there's a decrease in leptin. It's not seeing that the person is still obese and has plenty of body fat. It's just sensing, oh my goodness, they're losing body fat, and we need fat for survival, we need fat for fertility, So what it does, almost as a protective mechanism, is it stimulates hunger, stimulates food intake, and it decreases energy expenditure, trying to get that person back to where they were. So when we look at weight-reduced individuals, we almost have to look at them as though they're in this kind of state of starvation, and the body is trying to make them miserable enough so that they're going to eat and restore their body fat. This is just one example. There are many other signals coming from the gut, liver, and other tissues. And this is really just to show you the power of just one hormone. And if you look here, this is a leptin-deficient mouse. These are litter mates, and they are genetically identical, except for the fact that this mouse doesn't have leptin. And it's hyperphagic, it's obese, and it has many of the problems that obesity causes. So we do know that there are hormonal signals that are controlling body weight via hunger and metabolism. So with that in mind, we have to realize that sometimes diet, physical activity, and behavior therapy just isn't enough. So we do consider pharmacotherapy, and there are guidelines, and this is why at the beginning I said it is important to know a person's BMI, and this is one of the reasons is to follow the guidelines. So we consider pharmacotherapy if the BMI is 30 and above. If a person has obesity-related comorbidities such as diabetes, high cholesterol, sometimes it's even just a quality of life issue. Their joints are starting to hurt and they feel that they can't really run around after their children. Then you need to consider pharmacotherapy if the BMI is a little bit lower. If that doesn't get you where you need to be, then you can consider weight loss surgery for your patients. And similarly, there are different cutoffs whether or not there are comorbidities. It's either 40 or 35. The FDA has recently approved laparoscopic adjustable gastric banding for lower BMIs if there are comorbidities. So I think before we talk about adding drugs to a person's list of medications, we always take a look at the medications that they are on already, because sometimes we are involved in causing the obesity or exacerbating it. And there are many psychiatric drugs, neurological drugs, that do cause increase in body weight. And this can be quite extensive. Some of the antidepressants, like paroxetine, can cause 60 pounds of weight gain. So the idea is to try and consider drugs in certain classes that don't cause a gain in body weight, certainly steroid hormones. And this is really important to know. Since obesity really can trigger diabetes and make it worse, you don't want to add drug treatments that will cause even more fat gain, making a person more insulin resistant, and then they need more insulin, and you get on this cycle where your treatment is making the condition worse. So there now are medications in our armamentarium that we can consider that don't necessarily cause weight gain. So what about medication specifically for obesity? Well, it's been a very active year. Before this year, there was really only one medication that was approved for long-term weight loss, and that was orlistat. 2 new medications have been approved this past year. And I actually was talking to the internal medicine residents several weeks ago at noon conference, and I asked them who had heard of the 2 new medications, and not a single person knew what those medications are. So I'm glad that we have the opportunity at least to introduce you to the newer treatments. So orlistat's been around for over 10 years now. There was an over-the-counter form called Ali, which was almost as effective. It was about half the dose. That's recently been taken off the market because there was some evidence of tampering with the medication. Orlistat works in the gut. It's a lipase inhibitor. And in order to process and absorb fat from your diet, you need to hydrolyze the triglycerides into monoglycerides and fatty acids. Orlistat prevents that from occurring so that about 30% of the fat that is ingested isn't absorbed, and it goes through in the stool. Oops. I thought I skipped a slide here. The side effects with the orlistat, though, are related to gastrointestinal side effects, and you can imagine what they might be. It's fecal incontinence, a lot of gas, a lot of bloating. You're supposed to take it before every meal. If there's a lot of fat in that meal, the patient will be more symptomatic. But if you increase the fiber in the diet, then you can sort of lessen some of the side effects. So this is a drug that's about, lose about 3 to 5% of body weight. The other medication that we have are noradrenergic agents. These are not approved for long-term weight loss. They're approved for about 3 months of use, and they are, there are several of them. There's phentermine, there's a long-acting form of phentermine, and then you see tenuate diethylpropion. These were popular weight loss drugs, but they were removed from the market because they could cause hemorrhagic stroke. Now, why are these medications only approved for 3 months? It does seem silly, given the fact that I just showed you that people have trouble maintaining weight loss. So what the FDA has approved this for was 3 months, and that's because this is an old medication. And the clinical studies that showed the efficacy of phentermine were only a 5 to 6 months duration. The FDA now requires that drugs be studied for a longer period of time. These are highly effective agents, and I have to say that those in clinical practice do use them for the long-term treatment. This is why I was confused before. My slides are out of order, so I apologize. This is the orlistat study. Okay, and this shows you that here you have placebo and here you have orlistat, that it is more effective than placebo, but you can see it's not great. So the placebo subtracted weight loss, is about 3 to 4%. But what I do like about this slide is to look at the placebo arm, okay? It's pretty effective, and I think what it teaches us, particularly in the obesity field, that if you see a drug that's touted as a weight loss agent, you need to have that drug compared against placebo, because you don't know if it's really placebo or the drug itself that's causing the weight loss. And here we go. This is the side effects of the orlistat that I was talking about. The one thing I forgot to mention is that since this blocks fat absorption, there may be lower levels of vitamins, so a person needs to take a multivitamin when they take the medication. Oops. And I put liver failure here, just small with a question mark. There were some recent reports of liver failure, but it's unlikely to have been due to the orlistat because these individuals did have other reasons for liver failure. Okay, so what about one of the newer medications? This was recently approved. It's called lorcaserin or Belvic, and it has a very, very interesting mechanism of action. So what this does is it stimulates the 5-HT2C receptor. So there are many serotonergic receptors. Here are two others. And the importance of this is that it stimulates neurons in the hypothalamus, namely POMC neurons, that produce MSH, melanocyte-stimulating hormone, that we usually think of in the skin as causing pigmentation. But in the brain, MSH does have other interactions with other neurons to decrease appetite and increase energy expenditure. What these other neurons do is that they inhibit these POMC neurons, and when that happens, you get an increase in AGRP, which acts as an antagonist of MSH. Now, the importance of the specificity of serotonergic agents can't be emphasized enough. A number of years ago, there was a very effective weight loss drug on the market called Redux. It was taken off the market because it caused valvulopathy and pulmonary hypertension. The thing is that it interacted with other serotonin receptors, the 1B and the 2B. Okay, so it's very important to have a specific rate interaction with the 2C receptor.
Was that the drug called Ventolin?
Yeah. It really was highly, highly effective. But the company really has done a very thorough investigation with their clinical trials. They followed their subjects with, cardiac echocardiograms, and so far there really hasn't been a case of valvulopathy. This is just an example of the importance of the melanocortin, the POMC pathway. So MSH, which I just showed you in the hypothalamus, interacts with melanocortin-4 receptors. Okay, and here you see two brothers, one 9-year-old, the other 16-year-old. But this brother is defective in the melanocortin-4 receptor, and he's hyperinsulinemic, and as you can see, hyperphagic and obese. Melanocortin-4 deficiency does exist in the population, probably between 4 to 6% as a heterozygous mutation. So it is one of the more common forms of obesity. It is somewhat rare, though, to have a double mutation. So how does lorcaserin work? Well, it depends. About 50% of the people will lose greater than 5% of body weight, and much more than placebo. And about 20-25% will lose greater than 10% of body weight. So that's great, but then you also have to realize that about 50% of people will not really respond to the medication. Unfortunately, we have absolutely no idea who will be a responder and who won't be a responder. However, overall, in the clinical trials, you can see that lorcaserin is more effective than placebo. And this is one of my favorite slides here. And you'll see this kind of pattern with studies done on almost any weight loss agent. Here you see placebo over 2 years. Here you see lorcaserin. What they did here at 1 year was re-randomize those on active drug to continue with the drug or to be changed to placebo. And look what happens with the placebo. They go back and they meet the other placebo arm. And I stress this because what you will hear from patients, and also I get this question from other physicians, is how long do I keep this patient on the medication? Well, the answer for most people is that this is going to require chronic treatment. And we don't really think this way with other diseases. So, for example, if you put patients on a medication for hypertension and their blood pressure goes into the normal range, we don't then say, okay, your blood pressure is normal now, let's stop the medication and see what happens. We tend to think that way about obesity medication. Now, of course, not everybody is going to need chronic therapy. Sometimes they relearn certain habits, they learn how to eat properly, and they can come off the drug. The idea, though, is that most people will relapse, and it's very important to, if you stop the drug, to then be ready to restart it. So what are the side effects? Well, you have to remember this is a serotonergic agent. There is a potential for developing serotonin syndrome or neuroleptic malignant syndrome. And so you have to be careful what other medications that your patient is on. If someone has heart valve disease, just be aware of the potential for worsening of that, although there haven't been reports of worsening. Any drug that penetrates the blood-brain barrier and works in the CNS will have potential effects for mood disturbances. We don't necessarily see that much with the lorcaserin, but you need to watch out for that. This erectile dysfunction is very interesting in that, for whatever reason, MSH, which is stimulated in the hypothalamus, if you give these MSH agents to rodents, they will experience erections. So we do indicate that there is a chance for priapism. We're not exactly sure what the mechanism is. It may be by affecting circulation. But these are the most common adverse events, really headache, dizziness, and usually this isn't enough to stop the drug. The drug in itself doesn't really cause hypoglycemia, but if a patient is diabetic, they'll be on other medications for their diabetes. If they lose weight, you may need to adjust those other medications. So what about the next drug? Again, this was approved within the past year. Qnexa is the name for this medication when it was being studied. The market name for it is Qsymia. Now, this medication is a combination of phentermine and topiramate. Topiramate is approved for the treatment of seizures. It's also used as prophylaxis for migraines. But if you combine the two, you can get an agent that's quite effective for weight loss. And here are two different doses of the Qnexa, and it's pretty effective, 10 to 12% weight loss, and here is the placebo group. And again, not everyone responds, and people do respond differently, but the response rate for this medication is much better, so that 75 to 80% of individuals will lose more than 5% of their body weight. And actually, 9 to 15% of individuals will lose more than 20% of their body weight. So there certainly is a range of weight loss. Now the side effects, some are related to the side effects of phentermine, and that could be insomnia, dry mouth, change in mood, anxiety. Some are related to the topiramate, which has carbonic anhydrase inhibitor activity, and that's where you can get into trouble with kidney stones, hypokalemia, paresthesias. So people do have to make sure that they drink a lot of water, and also they may get some word-finding difficulties, and that's the topiramate part. The main issue of concern is cleft palate. So you have to be very, very careful that women of childbearing age are on effective contraception. And here you see with Qnexa, there is a decrease in progression to diabetes. This is with placebo. This is with the 2 doses. And you don't have to look necessarily at each of these bars individually, but basically this shows that there's a decrease in blood pressure, an increase in HDL, decrease in LDL, and also for the patients who were diabetic, there were decreases in their hemoglobin A1C. Now, I bring this to your attention because it's possible, hopefully, that by next year, this will be another new agent. And this is interesting. It's a combination, again, of 2 different drugs that are already out there. This is naltrexone, an opioid receptor antagonist, and this is bupropion, which is used for the treatment of depression, smoking cessation. And you can see that there's more effective weight loss with the medication than without. The studies right now are being done to make sure that there are no cardiovascular issues with this medication, but so far they look good, so this may be approved. Now, sort of what you're seeing, starting to see here, are combination medications and not just one medication. And if you think back to the slide, the leptin slide that I showed you, that's just one pathway. There are many, many pathways that control body weight. And sometimes targeting one of those pathways just isn't enough. So you need to use different medications in order for one to get effective treatment. And we see this all the time. I mean, you see patients for the treatment of diabetes who are on 3, 4 medications for cholesterol or for hypertension. Oftentimes you need different medications to get where you need to be in terms of efficacy. And I'm just briefly going to show the endocannabinoid system. There isn't a drug out there that we have, and I'll go over problems. But I just want to show this just as a way to stress, again, this highly regulated system for body weight. And there are endocannabinoids that we have in our system, basically marijuana-like molecules that cause metabolic disarray. And obese individuals have more of these endocannabinoids compared to lean. There are 2 different ones. Again, stressing that there are physiological differences between obese individuals and lean individuals. There were endocannabinoid receptor antagonists that were highly effective. Again, here's treatment versus placebo, and here's this re-randomization to placebo that we saw also with lorcaserin. The problem was that, again, as I said, any CNS acting agent can cause problems with mood, and there was anxiety, depression, some suicidal ideation, so the drug then never really came to market. So what about surgery? Right now, these 3 procedures are the most common procedures that we use for weight loss. There's the adjustable gastric band that places a ring around the stomach with this inflatable balloon, and that's connected to a port that is then placed underneath the skin in the abdomen, and you can inject saline or remove saline in order to increase or decrease the circumference, so that you have restriction to nutrient flow. The bypass also is restriction because now you have a stomach that is the size of an egg, and you bypass all the rest of the stomach and proximal small intestine so that nutrients flow differently, and that has many ramifications. The sleeve gastrectomy, basically, the surgeon cuts out about 85% of the stomach, so it's this restrictive process. And surgery works. This is an observational study here done in Sweden. We no longer do the vertical banded gastroplasty, but here is banding versus bypass. And unlike the weight loss curves that I showed before for diet, people lose weight. They gain weight back a little bit, but tend to keep most of the weight off. And this is over a 15-year period. There was a decrease in mortality. If you look, that starts to separate like around 7 years. So basically, yes?
I just had a quick question on the bypass. If you bypass that section of the small intestine, how do you get the pancreatic enzymes?
Good question. Okay, so they come in where they usually do, but they don't meet food until they meet the food here in the common limb. The standard bypass will not cause malabsorption of fat and protein, carbohydrates. There are more drastic forms where if you do a longer limb so that there's less interaction with the pancreatic juices, you will get malabsorption. But not, you do get vitamin and mineral problems here. Vitamin D, iron, B12. So that is an issue. So here you see the improvement in the mortality here. Also in terms of diabetes. And this has gained a lot of attention in that if you follow surgical groups out, there actually is a remission in diabetes. That's quite significant, although about half the people who go off their medications will have a so-called recurrence of their diabetes, and this is better than the control population. And also here you see the incidence of diabetes in the surgical group versus control. So part of my research and others' research is that we are realizing more and more that the gastrointestinal tract is an endocrine organ. And these are just some of the hormones that are made. And these hormones do control hunger, satiety, meal size, insulin sensitivity, insulin secretion. And what we think is going on with the bypass, because if you imagine, you're now making the stomach the size of an egg, and if you don't do anything for the person's hunger, they're going to try and get their 3,000, 4,000 calories down, and that would be a disaster. There'd be vomiting, staple line problems. So you have to deal with the hunger, and by rerouting food here, you change some of these signals that do talk to the brain and do decrease hunger and increase satiety, so patients are not miserable after the surgery. And this is just an example of one of the hormones. This is called ghrelin. It also is a growth hormone releasing hormone, but it decreases appetite, decreases hunger. Here you see ghrelin levels before breakfast. They decrease now. Before lunch, after lunch, ghrelin before dinner, decrease. What happens when individuals lose weight is that ghrelin levels increase so that they're hungry. You still get suppression with food, but now the individual has to combat increased ghrelin. And if you give people ghrelin, they will eat more at a buffet, and they'll report increased hunger. So that we know that this is a problem with diet-induced weight loss. And if you look at PYY, which is a satiety hormone, it increases when you have food intake. If you give people PYY, they eat less. Okay, and that works in obese and lean individuals. Similarly, for GLP-1, that increases after food intake. And GLP-1, while it does stimulate insulin secretion, it does work in the brain to promote satiety. And this is an example of one of our diabetes medications that I mentioned. There are some medications now that not only treat diabetes but may induce weight loss. This is a GLP-1 receptor analog, also known as Byetta. There are other analogs out there too under different names. So here what you see is, what I was showing before, that when you decrease fat mass, you decrease leptin, but you also increase ghrelin, and that works in the area of the hypothalamus so that you become hungrier and you decrease energy expenditure. Again, this is what happens during diet-induced weight loss. I won't go into the slides that we have for surgery, but basically I can tell you as an example, with the bypass surgery, you have increased levels of GLP-1, increased levels of PYY, and decreased levels of ghrelin. So with this anatomical change is causing a change in gut hormones that affect the brain. So you're operating on the gut.
What's the time? What is the minutes after a meal or after surgery?
This is after a meal. They get the meal, and this is 15-30 minutes. Okay, so this is a patient. This is sort of give you an idea clinically of what we do. 19-year-old college student, has some ADD, frustrated with his many weight loss attempts. He's hyperinsulinemic, even though his glucose level is normal and his A1C is normal. His BMI is 48. So we talked about lifestyle interventions, and he actually did well. He lost a bit of weight, went off to college, came back. This was a medication that was taken off the market, but you could substitute other medications. This is just to show you the effect of medications. It was causing some insomnia, but he's really responding. We gave him some phentermine. He thought it was increasing his insomnia. It turned out it wasn't. But we tried other medications. Eventually, he went back just to phentermine, but it shows you that, and he was exercising 1 to 2 hours a day, that you can work with individuals. And this boy lost 80 pounds, and his glucose really improved, as did his A1C, as did his insulin levels. Here's another case. This is a 38-year-old gentleman, has many of the problems associated with obesity, and was on all of these different medications, 4 medications for diabetes. His labs were terrible. Here you see his glucose, A1C, lipids. So he underwent bypass. He came off all of his diabetes medications, and as you can see here, he started at A1C of 9.9, and lost weight, and the A1C improved. You consider this normal. But the problem, and this is what I want to stress, is that he started to gain weight. He got a job as manager at Five Guys Burger restaurant, and that didn't help. But with weight regain, the diabetes is starting to come back. So again, these are just tools, okay? So even with surgery, diet, physical activity, behavior modification are important. These are some of the micronutrient deficiencies that you can get with the bypass that I alluded to before. And this is just to remind us that it's not just our hormonal environment that controls body weight. It's also our environment, period. So here, this feat of engineering, you can eat a Whopper and even perform surgery if you put this around your neck. So the problem is that our society is really geared towards overeating. And it's also geared towards ads that you see that are absolutely crazy with diet ads. And I bring this about to you because this is a multi-billion-dollar industry. Feeding to G tubes to lose enough weight for the wedding, colon cleansers. None of these work, and that's if in the best case scenario. In the worst case scenario, they can cause problems. This was a very popular medication, if taken off because it had meth in it. That will work. And this is a fat-burning supplement linked to liver failure. So this isn't an industry that is safe. So we need to find other sources of weight loss agents so that we can offer people help in their weight loss endeavors. And just to end, this is to remind you to set realistic goals with your patients. As you can see, it's very difficult to lose weight. Remember the other behavior modifications. And I think we're looking towards a cocktail of therapies for obesity. And I'll end at that. Thank you. Is there a time for questions? Or? Okay.
is it okay to just leave this sitting here? Did she wear that? I mean, I'm not walking around.
Oh yeah. This is pretty
This
loud.
is fine.
And
You're going to be out there working at Heather?
This is picking up everything. No. I was just saying everything is recorded for the full 2 hours. So if there's anything you don't want, in case you need any funny jokes.
There's an Indian girl, a black woman.
Is it?
You'll have to explain that. I said you'll have to explain that.
Oh, yeah,
They'll be going back to the tape and going, what? Yeah, that one.
One's taking back your. I'm just gonna step away from that.
You're like, I want nothing to do with that.
This is big. I'm supposed to eat.
That's all.
I know, because I'm in trouble. I think we might be. You want to use the mic?
Yeah.
Okay. But they can't hear you, they'll let you know. We go back and forth, and I will use this.
Just switch it over. So now it's working.
Yeah. You know what I'm saying? I'm gonna basically stand behind the.
That will work out better anyway because of our change-up.
Yeah. Sure.
That clock is wrong all the way down.
Oh, okay. Okay. So, yeah, I'm basically gonna stay behind that.
How's everything?
Okay. Stop. Oh my god.
Well, no, there was one time.
Oh my god. Well, I was glad to hear that What? What did you say? Did you say that you?
Exactly. You just need, oh yeah, I think it's actually after. Sorry. That's okay.
Question?
You can use that or this. If you're standing here, you might as well use this one.
This one?
So I'll just, you want me to start? Okay, it's on. You can start whenever you want.
Okay.
Which stand?
Okay. Got it. Good morning. Good morning. My name is Dr. Reed. I'm an endocrinologist, and I specialize in bariatric medicine. I see patients over at the Weight Control Center in Herbert Irving Pavilion, along with Dr. Corner, as well as our registered dietitian, Heather Bainbridge. And we'd like to thank you for inviting us here today to speak with you about the nutritional management of obesity. As you can see illustrated here on the slide, nutrition is both a science as well as an art that is used to help patients eat healthier. We have no disclosures. And our main goals today are to briefly review the definition of obesity as well as how to calculate dietary requirements for patients. We're going to review some basic food facts going over macronutrients, compare common dietary plans for weight loss, as well as some strategies for maximizing satiety. Obesity is a chronic and refractory condition that's characterized by an excess of body fat. Its causes are usually multifactorial and can be complex. And some of these causes may include genetic, physiological, metabolic, and emotional etiologies. And as Dr. Corner already alluded to, our society has changed in ways where we have foods that are easily accessible without expending a lot of energy. Also, we have highly palatable foods that act as motivators, and they are able to override the homeostatic signals that would normally signal the end of a meal. We also have social habits that can promote overeating, where you find people using food as a sign of love. And often our physical environments, our work environments, are set up in a way to discourage physical activity. So usually you'll see public spaces where it's quite difficult to find stairwells. All of these factors have contributed to the current obesity epidemic, and for these reasons, ongoing management is required in order to maintain a long-term weight loss. Calculating obesity, as Dr. Corner mentioned, is looking at a body mass index. You can do this by checking weight in kilograms over height in meters squared, or you could do it in pounds, weight in pounds multiplied by 703, divided by height in inches. It's also important to measure a patient's waist circumference, as this can give an additional risk for a patient. When you query a patient, you want to check whether or not they have other risk factors or comorbidities that are specifically related to weight, such as asthma, obstructive sleep apnea, or non-alcoholic fatty liver disease. And here you see the chart that has the classification of weights based on BMI. And in the overweight category, you see the BMI goes from 25 to 29.9. Obesity is a BMI of greater than or equal to 30. And as the BMI increases in obesity, there are 3 different categories of obesity. And you can also see from this chart on the side that having an increased waist circumference in any of the overweight or obese categories actually confers an additional risk for cardiovascular disease, hypertension, as well as type 2 diabetes. And before I get into specifics about making recommendations for weight loss, I will mention that some experts feel it's important to discuss with a patient whether or not they are ready to change. And basically this means assessing where a patient stands on the stages of change. And if they're maybe in the pre-contemplative or contemplative stage, simply counseling them on preventing further weight gain, or trying to move them along to the next stage. But this is kind of less important if a patient is coming to an actual weight loss center, since them having actually made an appointment and shown up means that they do have some readiness to change. Now, the treatment for overweight and obesity is divided into 3 broad categories, which Dr. Corner mentioned. The first being lifestyle modification, and this is the cornerstone, again, of all treatment for overweight and obesity. And lifestyle modification includes the cues, behaviors, and consequences that are associated with dietary habits, physical activity, and thinking patterns. Then you have pharmacotherapy, which was just reviewed, as well as bariatric surgery. We're going to focus on dietary modifications. So the current guidelines recommend that if you have a patient who's either normal weight or a patient who's overweight but does not have any risk factors related to weight, that they're simply counseled on preventing further weight gain. However, if you have a patient who's overweight and they have at least one weight-related risk factor, or if they're obese, which is a BMI of greater than or equal to 30, that these patients be referred for a comprehensive lifestyle program, which would include, of course, dietary intervention. And this program should be high intensity, last for at least 6 months, and it should be run by trained interventionists. And we know that for patients to lose weight, there needs to be an energy imbalance created. And this can be done by either decreasing their energy intake, increasing their energy output, decreasing the efficiency of energy use, or some combination of all of the above. And while we know that it's quite possible for patients to lose weight through just diet or just exercise, what we find is a majority of those who are successful are able to use a combination of the two. And this is particularly the case with the maintenance of weight loss. Now, before I go into creating a specific dietary plan for a patient, it's often helpful to find out what they're taking in at the present time. And this is done through a 24-hour dietary recall. And this is helpful at getting an estimate of their current caloric intake, their dietary composition, as well as meal timing. And it's often useful to use like food models such as these to ask the patient kind of for portion sizes and say how many times this amount would you be eating if you were eating a piece of fish. And you should also, we'll pass these around if you want to take a look at them. And it's also often useful to ask patients, what do you think your specific dietary problems are? Now, in terms of setting a weight goal for a patient, we already know that just 3 to 5% weight loss can actually lead to clinically meaningful health benefits. So our recommendations at the start of such a program is for 5 to 10% weight loss at 6 months. It's useful for clinicians to be aware that patients usually have goals that are much higher. They usually have a weight goal that's something that they might have attained at a much earlier time in life, such as their high school weight or an ideal weight that they saw on a BMI chart. And some studies have shown that patients going to a weight loss program, a lot of them stated that their average goal weight loss was 32% of their current body weight. Also, interesting and important for clinicians to know is that the most important factors for patients selecting their weight loss goal were appearance, physical comfort, and clothing size. So items such as treating a medical condition or a healthcare professional's recommendations, those came in much lower on the list. And regardless of this, regardless of whether or not your goals are slightly different, what's most important is to put the ownership on the patient and let the patient be aware that the amount of weight that they're going to ultimately lose is going to depend on what they're willing to put into the program. So 1 pound is equal to 3,500 calories. However, we now know that this doesn't take into account the body's response to metabolic changes that are occurring once you begin to lose weight. So to lose 1 pound a week, you basically want to set up a calorie deficit between 500 to 750 calories per day under a patient's total daily energy expenditure. And we'll discuss how to calculate that in just a minute. It's advised not to go under 1,000 calories a day unless it's closely supervised. And depending on their current calorie intake, if they only go 500 calories a day down, it might not be enough to create a 1 pound a week weight loss. So you really want to go between 500, maybe even closer to 750. Just remember that it takes longer for heavier patients to reach their steady state weight, and there are differences between patients, obviously. And they're going to lose weight at different rates, and that's totally normal. So there are many calculators available to calculate the total energy expenditure for patients. And just be aware, number one, you do not need to memorize these formulas. These calculators are readily available on any website. The Mifflin St. John is the one that's thought to be most accurate in obese patients. And it takes into account weight, height, age, and an activity factor. And the one below is from the World Health Organization. But a very quick method of estimating a calorie goal for a patient is simply, if you have a female or somebody who weighs less than 250 pounds, you can set their calorie goal between 1,200 to 1,500 calories per day. On the other hand, if you have a male or somebody who weighs over 250 pounds, you can set their calorie goal between 1,500 and 1,800 calories per day. Now, having a patient calculate calories can be a really great learning experience for them, particularly if you have a patient who's not losing weight and they just can't seem to understand why that's the case. But you do have to consider whether or not it's going to have value for any individual patient, since it can be time-consuming. There are several books out there and apps that are available for this, such as the ones listed. And even if a patient doesn't actually calculate the calories in the foods that they're taking in, it is quite useful to have a patient at least record about 3 days a week of the foods that they're taking in, so that you can get a sense of their dietary composition. You should also just consider the accuracy of a food diary when you're looking at it, and just be aware that some studies have shown that overweight patients tend to underestimate their dietary intake by about 30%, and females tend to report their dietary intake in a more socially desirable way. So they underreport their intake of fried and sweet foods. So after setting a caloric goal and having patients record their intake, you're going to need to monitor their progress in some way. And you do this by weighing the patient at regular intervals. And it's just important for us to be aware as practitioners that for a patient to be weighed in front of a stranger can cause some anxiety and distress. So we just need to be aware and practice empathy. Also, just be aware that there are several factors listed here, that can cause some fluctuations of a few pounds during a weigh-in. So now let's move on to some more specific nutritional details. It's useful to review some basic food facts with your patients to give them an idea of the calorie trade-offs they're making with certain food choices. You should make them aware of the fact that fat has 9 kilocalories per gram, compared with alcohol coming in at 7. So these are both calorie-dense food choices, compared with protein and carbohydrates, both at 4. And then lower than that are the sugar, alcohols, and artificial sweeteners. So now I'm going to move over and give the mic to our registered dietitian, Ms. Heather Bainbridge, and she's going to go into more detail about the macronutrients for you and some healthy food sources for each of them.
Okay. Can everyone hear me okay? No. No? Okay. Any better? All right, thank you. So we're going to start with the fat group. And fats are necessary for providing essential fatty acids and fat-soluble vitamins. It's essential for brain function, growth, and cushioning for organs. Foods can also be considered fats, or they can contain varying degrees of fats. And this is where patients can have a lot of misconceptions around this food group for whatever reason. So I'm going to go through it with you in a little bit more detail.
1 serving of fat, and this is usually liquid fat or full fat, like oils, butter, full fat mayonnaise, lard. 1 teaspoon equals 45 calories, and this is what a teaspoon looks like. It's not very large. And then if someone is having a tablespoon of low fat or reduced fat, such as reduced fat salad dressing, this is what that serving size looks like. A lot of people tend to think of fats in terms of tablespoons, and so we have to readjust their idea that we need to start looking at it in serving sizes of teaspoons to not get too many calories in our diets. And you can see the sources listed here, the ones that I did not mention. So other large sources of fat are poultry skin, red and processed meats like sausage and bacon, eggs, chocolate, sweets, and snack foods. And oftentimes we have patients that tell us, the butter that I have, it takes 6 months for me to use it. And often it's because people eat the majority of their fat from hidden sources. Prepared foods, fast foods. So we just want to keep this in mind when we're educating our patients. And then move them towards healthier sources, such as 1 or 2% milk, reduced and low-fat cheeses and yogurts, avocado, nuts, canola oil, and extra virgin olive oil. And just to note that canola oil and extra virgin olive oil contain the same number of calories as butter, but it's the fat composition that makes it healthier, and that's why we gear people towards that. But it's certainly not calorie-free. I've worked with some chefs, and they have this feeling or this thought that it is calorie-free just because it's healthy. So we just want to make sure that people realize that that's not the case, but they're encouraged to use this over butter. Lean ground chicken, turkey, and beef. Many people buy between 80 and 85% lean when they're at the grocery store. So we give the number 90%, so when they're at the store, they can see a specific number to buy that type of ground meat or turkey or chicken. And then salmon, tuna, sardines, and hummus are also sources of fat. I highlighted nuts and hummus because oftentimes people think those two items have a lot of protein, when in reality they actually have more fat. And I consider fat more like a condiment, like a reduced fat source than a protein source, if you look at the breakdown. And then moving on to protein. So protein is necessary for building and maintaining muscle and bone mass. Foods have varying degrees of protein and contain both fat and carbohydrate, which then will increase their total calories. Yes?
That's kind of unrelated, but
that's a bagel. We'll talk about that in the next slide. It's not as unrelated as you think. So getting back to protein, 1 ounce has 7 grams of protein. The salmon food model that's being passed around, that's 3 ounces. So 3 times 7, that contains 21 grams of protein. Some research suggests that consuming 20 to 30 grams per meal is beneficial for satiety, bones, and muscle mass. It also has been shown to help to suppress ghrelin longer, the hormone that Dr. Corner spoke about. So that's another reason why we want to make sure that our patients are having balanced meals that include protein. And there are 4 categories that I wanted to highlight for you. The first category, extra lean, which roughly contains per ounce 35 calories. This is 2 egg whites, going up to all 99% lean ground chicken or white meat poultry, shellfish, cod, flounder, other non-fatty fishes, cottage cheese, buffalo, venison, and a half cup beans and legumes. Beans and legumes also contain carbohydrates, so they have 35 calories of protein and then another part coming from starch, so they're closer to 120 calories per that half cup serving. We still recommend it, but I just wanted to note that. Lean proteins are about 55 calories an ounce. They consist of the dark meat or white meat with skin. Patients are relieved when we say that you can have lean products as well because it does have a little bit more fat and a little bit more flavor. But our recommendation is if you can get 1 or 2 ounces from, say, white poultry with skin or chicken with skin, and then have the rest from the chicken breast. That helps to balance the calories a little bit better. Canadian bacon is another choice to substitute out for bacon, and that people find quite enjoyable. And you can see the other sources of protein listed here, specifying to your patients the type of red meat, such as sirloin, filet mignon, flank steak. So when they're at the restaurant, at the grocery store, they're able to hone in on that and pick the lower calorie option. And then medium fat, that contains 75 calories per ounce. Tofu and tempeh are listed here, but they're healthier sources. They contain healthier type of fat. So we don't discourage this, but this is just when keeping in mind the overall caloric balance. Even if you're eating healthier foods, if you're going over the amount that you're burning, it's going to make it harder for you to lose weight, or for your patients to lose weight. You can see the other options listed here. And so we want to not exclude these options, but just minimize if a lot, and watch if there are a lot of these food sources coming from this group. And then the high fat group, which is 100 calories an ounce. So again, this is some math that you can all do quite easily, but if you eat 3 ounces of spare ribs, you're getting 300 calories. So just reminding patients about how expensive these types of food can be and how they can be minimized. Peanut butter is listed at last there as well. It's a healthier source of fat, but still educating or reminding people to be mindful of their portions. And finally, the carbohydrate group. So this gets demonized in terms of weight control, but really it's the preferred source of fuel for the brain and muscles, and it spares protein. Foods that contain carbohydrates are food groups that have 12 to 15 grams of carbs per serving. And these are starches, starchy vegetables, beans and legumes, fruit, we see hummus again, yogurt products, and milk. So we did not see hummus on the protein page. So this means that we consider hummus more of a carb and a fat than we do a viable protein source, despite what the media and advertisers will tell us. But healthy nonetheless. So the serving sizes, 1 ounce of bread is considered 1 serving, which is roughly 80 calories. A 1/3 cup dry pasta and rice. And you can see as the list goes on, that's listed there for your reference. Now it's reasonable to have a 1/2 to 1 cup starch per meal. Depending on your activity, that bagel floating around is 1/4 of a bagel. So 2 of those would equal 2 servings of carbohydrates, or 160 calories. White and whole wheat starches are similar in calories. However, whole grains provide a higher health benefit, and that's why we want to gear our patients towards those choices rather than enriched grains. Non-starchy vegetables, although you can see low in carbohydrates, they contain 5 calories per gram. Are low. However, for shorter people, if they're eating too many vegetables, it might take them over their calorie level. So we still want to be aware of people overeating in areas that even if they seem healthy. Another food, milk also is another controversial food, but just so you know, it contains the same amount of carbs, protein, and calcium. It's the fat content that changes the total calories. So if you're drinking whole milk, you're going to get the same amount of carbs than if you're drinking skim milk. And then a 1/2 cup, but the difference in calories is you'll drink 150 calories per cup of whole milk, and about 80 to 90 calories of per cup of skim milk. And then a 1/2 cup of dried fruit and a 1/2 cup of fruit juice contains the same calories as 1 whole fruit, but the serving is much smaller and lacks fiber. We'll discuss more about that. I'm going to hand over back to Dr. Reed to go through eating plans.
Thank you. Now, for any eating plan to be successful, really the most important component is that there's a caloric deficit that's created. And you can do this based on your patient's food preferences, and there are several plans that can work. Some patients may want something that's more structured, in which case you can offer them meal replacements. Some other patients might want to do calorie counting where they're choosing their own foods. And other patients might want very specific dietary recommendations. And regardless of which type of plan you use ultimately, it's always valuable to have handouts to give to them. The next two slides have a lot of information on different types of diets that are used, and there's a lot of information here for your reference. I'm just going to highlight a few of the diets and some main points regarding them. So first is the Atkins diet, and this is a high-fat, high-protein diet, and basically what happens is once your body's carbohydrate stores are depleted, your body starts to use ketones as a source of fuel. If a patient is able to adhere to this diet for a long period of time and adhere closely to it, they are able to experience some side effects such as some fatigue, nausea, dizziness, and possibly even some hypokalemia. However, most patients don't adhere for such long periods of time to it and so closely. And even if you do experience a few of those adverse effects, it's not such a big deal unless you're somebody who has a weakened system to start with. So if you had multiple medical comorbidities to start with, then it might be an issue. But for a generally healthy person, that's really not a problem. The paleo diet is a diet that's high fat and low carb, and it's supposed to mimic the diet of our hunter-gatherer ancestors. So in this diet, you're basically having a lot of fats. You're not allowed to have any grains or beans, and the only carbs in this diet are coming from fruits and vegetables. The Mediterranean diet is a diet that has moderate to high fat, but the focus is on getting quality fats in the diet, such as monounsaturated fatty acids coming from nuts and extra virgin olive oil. And this diet has actually been shown to help with patients who have diabetes, helping them achieve improved glycemic control, also with patients who have polycystic ovarian syndrome or those who have insulin resistance. And now we'll look at a few on the next page, starting with the DASH diet. And this stands for Dietary Approaches to Stop Hypertension. This is a low-fat, moderate carb diet, and the low fat really focuses on low saturated fat, coming in at 6%. And this diet has the low fat, it's actually high in whole grains, and it includes a lot of poultry, fish, and low in sodium. So this diet has been shown to actually help treat hypertension. The Weight Watchers diet has a variable macronutrient composition because the general thought with Weight Watchers, their philosophy is that as long as you stay within your point allotment, you can eat whatever you want. And every person's point allotment for the day is determined based on your current weight. And 1 point is the equivalent of 50 calories. The Ornish-Pritikin diet is an extremely high-carb diet, and it has many health benefits, including the ability to actually reverse heart disease. The issue with this diet is it's very difficult for patients to adhere to it. And the control diet that's listed on both of these slides is representative of the typical American diet, which is very high in fat and high in carbs, and it's very low in fiber, coming in at 14 grams. And just to give you an idea of how fiber poor the American diet actually is, this is a slide that shows you the most popular sources of fiber in the American diet. And these foods certainly aren't ones you think of when you think of fiber foods. Okay, so with all of these diets out there in the popular sphere, patients still often come in and they're asking me, Doc, which diet is the best one for me? Which is the one that's going to help me lose the most amount of weight? And this is a study that can help shed some light on that. So this was a study that took some overweight patients and they put them on one of 4 popular diets for a year. And at the end of the year, they were looking to see who did best in terms of weight loss as well as reducing cardiac risk factors. And what you see at the end of a year, actually weight loss was pretty modest. It ranged just from 2 to 3.3 kilograms, and adherence rates, which are in parentheses, were pretty poor, so between 50 to 65% of the patients. And what was most interesting about this study was that whether or not a patient was successful at losing weight or reducing their cardiac risk factors did not depend at all on which group they were assigned to, which weight loss diet they were assigned to, but it was solely dependent on whether or not the patient reported having adhered to the diet. So simply put, the best diet for any patient is the one they think they can stick to. That's it. Now, often patients come in, they get frustrated, and they might say, you know, look, doc, if I eat any less, I'm going to be starving. Or they might come in and say, I'm not eating that much. Why am I not losing weight? And in some respect, they're really correct. You know, they may not be eating a lot of food, but they're eating too many calories to lose weight. And basically, you know, to lose weight, we've already talked about how you need to create a caloric deficit. So, and once you start to lose about 10% of weight, we've already mentioned how ghrelin, also known as the hunger hormone, is going to start to increase. So patients are going to start to actually have an increased appetite, and if they actually stick to the caloric limit that we've already prescribed them, they may in fact feel like they're starving. So we're going to have Heather Bainbridge come back, and she's going to go over some important concepts and strategies which are going to help patients achieve a sense of satiety while consuming fewer calories.
Alrighty, so there are classifications of food that's helpful for weight loss and satiety. Can you hear me again? We're good? Okay, great. So the first one we're going to discuss is energy or calorie density. And it's the number of calories or energy in a specific amount of food per gram. And there are 4 components that are focused upon in studies, and they are how water affects the energy density. So an example is raisins versus grapes. You can envision how small raisins are. So a 1/4 cup of raisins is calorically equivalent to 1 cup of grapes. Fat, ice cream versus low-fat yogurt. Fiber, broccoli contains more fiber per calorie than white rice does. And air, popcorn, 3 cups of popcorn is equivalent to maybe say 20 of the small pretzels. So we can see this will fill people up a larger volume on less calories, because what the research has shown with energy density is that people can eat about the same amount of volume per calorie or volume of food daily. It's not that they hit 2,000 calories and stop. It's that weight that does make a difference, and that's how we can help them increase their amount of volume for less calories. And then it makes sense that a high energy density means it contains a lot of calories per gram, and a low energy density means it contains less calories per gram. A similar way of classifying food is through nutrient density. This is a little bit newer than energy density, and it considers the whole nutrient package of food and is calculated based on how many nutrients per 100 calories. And it focuses on 9 nutrients that promote health, such as protein, fiber, vitamin A, C, and E. And then it's also 3 nutrients that people are encouraged to minimize in their diet: saturated fat, added sugars, and sodium. And it spits out numbers of where foods can be classified as. And high nutrient-dense foods, to no surprise, are whole grains, fruits, vegetables, dairy, and lean proteins, while the non-nutrient-dense foods are potato chips, white bread and starch, soda, non-fruit juice, and high-fat proteins. And I think this picture is worth 1,000 words, and this is indicating how energy density can work. So you can see, oops, sorry about that. You can see this sandwich on your left. There's added vegetables, a leaner protein, lean roast beef, less cheese, compared to the bologna sandwich with thicker cheese and less vegetables. So you can see by adding more vegetables, which increases the fiber, which reduces the energy density, as displayed by 429 calories versus 626 calories can help people feel full on less calories. Another study done in children, interestingly enough, and what they did, they randomized children to different groups, the chip group, the cheese group, the vegetable group, or a combination group of cheese and vegetables. They were looking at the nutrient content of the foods specifically. And they plopped them in front of the TV, and they said, here are these snacks. Eat until your heart's desire. And they came back, and they saw that the kids in the chip group ate the most calories, 600. You can see as the other options, the children ate less. And what they found is that children consumed 72% fewer calories than the children in the combined snack group. So their thought is that by combining higher nutrient-dense foods, it helps to increase satiety. And this is how we use this in clinical practice, is not just only saying have all the vegetables you want, but sometimes containing different food groups, such as a protein that's in cheese, and then the vegetables that it contains more fiber is more satisfying for people to eat less calories and still feel satisfied. Moving on to the glycemic load of food. This is a measure of food that takes into account both the amount of carbohydrate in food and the impact of carbohydrate on blood sugar levels. It's derived from the glycemic index, and it's classified into 3 categories: low, medium, and high. And oftentimes we have people saying to us, oh, I heard that that carrots are really bad for me. I should avoid carrots, right? And what they're thinking of is the glycemic index, where the glycemic load takes into account the actual portion that we would eat in our diet. And so by using these, by no means is the glycemic load a perfect way for people to eat only, to only follow, but it does help us have a better idea of where our, about healthier sources of carbohydrates. And so if they were to have carrot juice, that would be different. That would then turn into a high glycemic food, but eating carrots is considered low. And then this can be used to help people eat higher quality carbs, just as I indicated about having people choose brown rice versus white rice. And so again, our goal is, and to repeat this to our patients, to remind them, we want to reduce the overall calories, but promote the feeling of fullness. And that's what these strategies do. And finally, fiber. And I love fiber because not only does it help with weight control, but it also helps to prevent diseases. And so there are a couple different sources of fiber listed here. I don't specifically talk to patients about, oh, you need to increase your insoluble fiber or soluble fiber, because fruits and vegetables contain both. But it's just the amount, the proportion between the two that differ. And I've listed examples to help you make your recommendations. And so insoluble fiber, it increases the water holding capacity of undigested material. And it leads to increased fecal volume, so more bulk, and decreased GI transit time, so that increases the frequency of defecation. So this is very helpful for, not surprisingly, people who are constipated. And then when people come to you complaining of constipation, this can be also a way that you're helping them become more regular, and also can be helpful in weight control. And you can see the examples are listed here. Next, soluble fiber. So this works by forming gels, resulting in a low GI transit time and slowed in nutrient absorption. So this is helpful for constipation prevention and people who have high cholesterol and are motivated to lower their cholesterol. And these examples are listed here. And then lastly, resistant starch. There are 4 types, but I've listed 3. Resistant starch 1, this makes up physical and digestible starches found in seeds, legumes, and unprocessed whole grains. RS2, this is resistant to digestion because it contains a high amount of amylose versus amylopectin. And amylose has less surface area in the GI tract, so less calories are absorbed. This is found in fruit, potatoes, corn, some legumes. And just to keep in mind that longer cooking times decreases the amount of resistant starch. So it's steaming rather than boiling, for instance, not overly cooking are grains. The one exception to this are foods that contain resistant starch 3. And so this is interesting because when starch-containing foods are cooked and then cooled, it actually decreases, it becomes less soluble and when it's heated and then cooled. And so examples are legumes, bread, cooked and chilled potatoes, pasta salad, and sushi rice. Having pasta at night and then having the leftovers cold the next day will decrease the absorption of calories. And the decrease is, if you remember what Dr. Reed had said, carbohydrates contain 4 calories per gram. 2 calories per gram is what gets absorbed in foods that contain more resistant starch. And then this is just a slide to summarize balanced food choices and just to highlight the last one. Oopsies, sorry. Balanced, high nutrient dense meals and snacks provide the highest level of satiation more than non-nutrient dense foods. So this is getting the idea of not excluding the macronutrient groups, checking if your patients are having lean protein, a high quality carb, and healthy fat. This tends to promote satiety overall and decreases feelings of deprivation. Next, meal replacements. So we're going to move to more strategies to help people find ways to stay within their calorie goals. So meal replacements contain a fixed amount of calories, making it easier to meet goals during weight loss and maintenance. They're highly useful because they're convenient, they provide structure, they're inexpensive, and offer stimulus control. A big part for people that are eating these days is convenience, and this is a way to help to bridge that gap between being convenient and also not skyrocketing calories. And Dr. Corner had talked about the research showing their efficacy. And then this is really helpful for people that want to keep their calories to 1,200 calories or less, because it's very difficult to eat 1,200 calories on conventional foods. So we recommend to include 1 to 3 meal replacements a day, but to replace 2 meals. And the third one would hypothetically be a snack. And then examples include protein shakes, Weight Watcher type meals, protein bars. And then very low calorie diets is not recommended unless under medical supervision and provided by trained practitioners are delivering highly intense lifestyle modification sessions, because the success just isn't there for people that are doing it on their own. And Dr. Corner showed that slide. But you can see the success in weight loss when on these plans. During the transition period, when people are coming off a full liquid diet and onto regular foods again, food is slowly introduced while the meal replacements are slowly coming out. It is normal to have some weight gain due to water shifts when on this plan, so you can reassure patients that it's normal, but they still should be able to lose weight. So it's balancing the two. If they're coming back every week, gaining weight, that's more suggestive of a problem than occasional fluctuations. And then weight regain has been shown to occur in people not following up with a weight management program. These are behavioral interventions are very helpful in supplementing the nutritional information. It's not just the knowledge that helps people, but it's also implementing it that makes a difference. And so some that we'll highlight is self-monitoring at follow-up. It's the key component to increase awareness about the specifics of habits. The second benefit is that it can help the patient identify triggers, see their patterns. It's kind of like spending. You might know what you spend every day. You'll remember the big purchases, but it's very hard to remember maybe the small things like buying a pack of gum. And this is the same type of idea that happens with food intake. We like to follow up with them on their goals and set and teach them how to use their self-monitoring tools to their advantage, so it becomes useful for them. Some people just don't want to write down their food in a food diary, and that's fine. Weighing counts is another form of self-monitoring that's quite helpful. Using the technology out today, Strive is a pedometer that you can all download on your smartphone, and it's free. And what's really nice about it, it provides incentives, such as when you've walked a certain amount, it says you've walked across the Golden Gate Bridge. And believe it or not, these types of motivational reminders are really helpful for people to get them engaged into a more regular walking program. And these other ones you can look at at your leisure. So, helpful adjunct nutrition goals. So, we don't only want to address what people are eating, but how they're eating, because sometimes how they're eating can help with what they're eating. So just a couple that help a lot of our patients are placing the fork down between bites. Often, you can probably relate, you're rushing, you're studying, you're shoveling food as quickly as you can at your meals. Placing it down between bites can slow down the meal and give the body that 20 minutes. Because we don't start feeling full until after 20 minutes. Another one that people find helpful is that drink water first when cravings hit. Is because when we're dehydrated, we tend to crave sweet foods. So this can be helpful for people that often say they have sweet cravings. There's a chance that they could be dehydrated. At the very least, it helps to provide a little bit of a distance between initially having a sweet craving and going for it, so that it can have two benefits. And then weight maintenance. This is phase 2 of the weight loss effort. It's a crucial part of the weight loss process and is consistently overlooked. As Dr. Reed and Dr. Corner mentioned, there are hormonal adaptations and physiological adaptations that make it harder for people to stay at a reduced weight. But often patients don't think that. They think once they've lost weight, they've somehow changed, and that there's not that much risk for weight regain. So we want to keep in mind that it's typical for a patient to hit a plateau between 6 and 12 months, with the greatest weight loss at 6 months. And at that point, to recommend that people have a 3 to 5 pound warning weight, that when they see their weight go up, they take action. And then there is an energy gap. For every pound lost, they burn less calories per day. And then next is that recommendations are for maintainers to participate in long-term weight maintenance programs because they tend to be more successful. And then to discuss habits of how people who lose weight and successfully take it off, researchers have looked at individuals who have kept at least 30 pounds off over the course of a year, and they ask them their habits. You can go to that YouTube video when you get the chance. And this is what they do. They follow a low-fat diet. They move 60 to 90 minutes a day. And I just want to touch upon this, is that a lot of times doctors will hear, or people will hear, that their patient's exercising 90 minutes and thinks all of a sudden they're being too fanatical, when in reality it is an amount that people need to be active, and unless they're doing it when they're injured, there's really no concern for people being that active throughout the day, and the majority walk. And then it's not just putting a weight, a 3 to 5 pound weight warning on your plan, but also to have a plan if your weight increases a few pounds. We're finishing up just to address resistance. This is, again, combining the art in weight management. People can usually have a lot of knowledge, but it's helping them successfully negotiate what their issues are around changing their habits. So you want to convey that you're going to partner in this. You both bring about different types of experience and expertise. Evocation, you want to highlight and repeat back to them their stated beliefs of weight loss and elicit the benefits of no change. Let them see both sides. And then just remember that we want to remain curious about reasons why people aren't eating or exercising the way that they should. And encouraging experiments can help people test out their changes. Finally, just to address an eating disorder associated with obesity, it's called binge eating disorder. It's in the DSM-5. It's defined as eating a large amount of food in a discrete period of time with a sense of loss of control during the eating episode. The majority of individuals, though, who are obese don't have BED. It's a matter of definition and degree. It's estimated about 1/5 to 1/3 of people who have obesity also have this psychiatric condition. And so it's similar to saying that people who diet have anorexia. It just doesn't add up. So it's people that are eating a lot of food and are doing it for reasons that could be addictive or dissociative, if you see the two categories here. And it can also be caused by, there's also the deprivation-sensitive category that's caused by dieting. Interestingly enough, the goal of BED is to treat the condition. It's not weight loss. So it's stabilizing eating patterns, developing positive coping skills, and focus on behavior, not weight. And then referring out to an experienced mental health clinician or RD to help adjunct with your visits to help with this change because it's difficult for those. And then finally, here are recommendation readings for yourself and for your patients that you can read when you get the chance. So thank you.
Oh, question?
You talked about reducing intake and increasing energy expenditure, and then you also talked briefly about changing the efficiency of the way your body processes calories. Are there any kind of like 1 to 3 quick strategies on that?
So with the change in the efficiency of the body, that's something that your body actually just does. So really you try to counteract that by increasing your exercise. But with the decreasing your intake, obviously those are the strategies that we've discussed here today. It's really a matter of decreasing your caloric intake by whichever means you want, whether that's by decreasing your portions, by having a prescribed doing meal replacements. That's kind of with all of the methods we talked about. Increasing your energy output is just, increasing your exercise. So again, and that's also very individual, however you want to increase your exercise. In the weight registry, if you look at that video, a majority of patients in there actually walk. That's what they do to increase their energy expenditure, their output. It's walking.
Another food-related to address that is including more fiber in the diet and resistant starch types of foods. So as you can see up there, I think this is working, adding more water or air content can help increase satiety. So having people switch out, have popcorn instead of potato chips, having broth-based soups, having salads at a meal, adding more vegetables to there instead of having 2 cups of white rice, having a cup of vegetables and a half or 3/4 cup rice. So those are ways that people can feel more full and less calories, and reminding them that's what the strategy is, because they might not believe you, and that's perfectly normal. So those are some, that is talking also about the efficiency of use as well.
Thank you.
You're welcome.
Don't steal our food medals.
Oh, I know.
Oh, I know.
Ah, thank you.